Okay, good morning. Today we continue with the chapter NCDs. And if you remember last time, these are the 5 strategies that are used to address or combat or control the NCDs: screening, intervention, treatment, counseling, and research. Still, we are in the screening. Let's continue. And we were here last time. So this is criteria 3, feasibility and testing strategy. First, in order to run a screening program, we have to identify our risk group, such as women above 35, if you are going to screen for breast cancer, or men above, let's say, 50, if you are going to screen for prostate cancer. So the first step is to identify the risk group. This will make life easier for you. It will save lots of money, save lots of resources, and so on. Secondly, we have this idea of multiple testing. We have 2-stage testing, or we call it sequential testing, okay? And why do we use this? Because we want to distinguish or even minimize the false positives and the false negatives. We will discuss this in a minute. So first, in 2-stage strategy or sequential testing, we have 2 things to do, or 2 steps, or 2 phases. First, we screen using screening tests, which are usually fast, cheap, and non-invasive, and sensitive. Then, if we have positive test with screening, then we go for confirmatory. Only after the positive screening test, we go for confirmatory test, which is usually takes more time, expensive. Most of the times it can be invasive. Patients don't like it, but it's very sensitive and very specific. So we have screening test level and confirmatory test level. And as you see here, we only go for confirmatory if the screening is positive, as shown here. Look, screening, negative. So when negative, we stop because usually screening tests are usually sensitive. But if positive, then we go for confirmatory. Never ever depend on screening test to make final diagnosis. No, that's a big mistake. We have to do screening should be positive and confirmatory should be positive. Then we can say you have lung cancer, you have prostate cancer, you have diabetes, or you have hypertension. Exactly. But if screening is negative, usually, well, some physicians, the screening, they will do it multiples, 2, 3 times. Negative, then, because it's usually very quick, non-invasive, and cheap, so they will do it 2, 3 times. Like if you suspect diabetes with a patient, you do FBS, fasting blood sugar, maybe 1, 2, 3 times on different occasions. Today, maybe after 2, 3 days, and next week. If still you got above 110, then you go for confirmatory. That's the idea. Okay. Now we go to concepts which are very important in clinical chemistry and epidemiology and public health. These concepts are validity. What is validity? Sensitivity, specificity, accuracy, precision, positive predictive value, negative predictive value. These are very important to know for you. So if I say this test is valid, what do I mean? I mean it's highly sensitive and highly specific. What do I mean by highly sensitive and highly specific? In epidemiology and public health, we use this definition: sensitivity, ability of a test to identify correctly those who have a disease. What do I mean? That the test is positive, you make a test, screening test, it's positive, and the patient, he or she has the disease. Really? Because sometimes it tests positive and the patient is healthy, undiseased. So when the test is positive and the patient is really diseased, then this is sensitivity. Or sensitivity is related to positive tests. So sensitivity all the time in your mind should go to positivity. Specificity at the same time, ability of a test to identify those who are undiseased, those who are healthy. So the test is negative and the person is, or the patient is healthy. Negative and healthy, which means this is specificity. And it's a test of negativity. So all the time, when somebody tells you sensitivity, then you go to positive cases. When somebody tells you specificity, you go to negative cases. Yes? Both. Yes, these two concepts, they describe one test. You can describe one test by these two. Look, now I am going to tell you something. You might ask me that we have had another definition in clinical chemistry. I will tell you yes. Why? Because there are two definitions for sensitivity and specificity. One definition is related to diagnostic. We call it diagnostic sensitivity, diagnostic specificity, where you tell that the patient has the disease or not, diseased or undiseased. So this diagnostic sensitivity is related mainly to the outcome of the patient, diseased, undiseased. We call this type diagnostic sensitivity, diagnostic specificity. At the same time, in clinical chemistry, we have another definition, which we call analytical sensitivity and analytical specificity. What do we mean by this? In clinical chemistry, the analytical sensitivity is the ability of a test to detect the minimum concentration of the analyte. So you are looking for PSA, prosthetic specific antigen. So the minimum amount that the test can go down to and detect is called sensitivity. This is analytical sensitivity. And usually sometimes they call it LOD, limit of detection. Mainly related to the amount of the analyte. But while this diagnostic sensitivity, mainly it relates to the outcome. Okay, so what is specificity? Analytical specificity is the ability of the test to detect the analyte of interest. What do I mean by this? Imagine you have a tube, and this tube contains serum. This serum contains analytes such as A, B, C, D, E, F. These are analytes in the tube. And you are interested in detecting analyte B. Analyte B, not A, not C, not D. They are all inside. Usually in serum, you have many things inside the serum. A good specific test is the one that can detect analyte B in our example and does not detect analyte A or C or D. This is specific. It went and detected what you really want. In some cases, the test can detect analyte B and also analyte C and analyte A. How come? This is not specific. If the test can detect with B, A and C, then the test is not specific. If there is no B, then I will get positive because of A. If there is no B, then I will get positive because of C. Why does this happen? It happens because of two things. Cross-reactivity. A and B and C maybe are very similar. So the test does not distinguish between A, B, and C because of high similarity. So it detects positive. This we call cross-reactivity or interferences. There is something coming from outside your system, fall into the tube, and was positive. That's the definition of analytical specificity and previously analytical sensitivity, which we are not interested in this course actually. In this course, we are interested in the diagnostic sensitivity and diagnostic specificity. Understood? So far, so good? Continue the concepts. We have PPV, positive predictive value, NPV, let's talk about these two first. Okay, what is positive predictive value? The proportion of patients who test positive and actually have the disease. In the sensitivity, just the difference, because what's your name? Muhammad. In the sensitivity, you are interested in knowing or looking at the patients who have cancer. In positive predictive value, you are interested in the group that is positive, regardless it has cancer or not. Look, we have an example in this, and I will explain it in an example. Okay, good, Muhammad. So, proportion of patients who test positive and actually have the disease. Are there some people who test positive and they are normal? Yes, it happens. We call this what? False positive. PPV here reflects precision. Precision in analytical situation, where we call analytical precision, is the amount of repeatable results that you get. What do I mean? You are testing for glucose, and in trial number one, attempt number one, you got 120 milligram per dl. Number two, 119. Number three, 121. So you are all the time hitting the same target, around 120. This is precision. We call it repeatability, repeating, or reproducibility. Your results are reproducible. That's analytically talking. Okay. Negative predictive value. Look at this. Proportion of patients who test negative and they are actually undiseased. They're actually healthy. So negative and healthy. Positive but with disease. This is positive predictive value. This is negative predictive value. What is accuracy? Accuracy is this. Proportion of patients who test truly positive or negative, who test truly positive or negative of the whole sample population. What do I mean by this? Test truly. What do I mean? They are positive and with disease. Or negative. And negative. This is what I mean by exactly. Good what you said. So test truly is positive with disease, negative with and undiseased. This is test truly. Okay. This will be, yes? Yes, accuracy, it reflects all. Exactly. Good, Hamad. Okay. NPV. Look, he's asking me to repeat. I am not going to repeat. Why? Because the example that is coming will explain everything. Just a moment. We have an example. All the time give examples, then the students will understand in most cases. Okay, this is an example. Look, calculations, calcs, an example, a population of 1,000 women, prevalence of breast cancer is 10%. So here we make a 2x2 table, contingency table we call it, 2x2 contingency table, cancer, the disease, no cancer, undiseased. And we have the mammography screening test, positive, negative. So we have 1,000 cases. Of these 1,000 cases, how many cancers we have? 10% of the 1,000, which is 100. So the 100 comes where? Here or here? Cancer. Very good. So 1,000 and good, 100. How much non-cancer? 900. Easy. Okay. Then, good, 900. Then, test did not catch 10 cancer cases. They are cancer, but the test gave them negative. So the 10 should be positive or negative? Negative. So the 10 comes down here. So if this is 10, how much is this? 90. Good. Exactly. Very good. Finished with this. Now we go to this, the second part of the sentence. 90 of the non-cancer, this here, were positive. So 90 is here or here? Above here. 90. How much are we left with here? 8, 10. Very good. Very nice. So complete. The table is completely filled. So just a quick mathematics, 180, 820. Now let's calculate sensitivity and specificity and PPV and NPV. Very cool. And plus accuracy. Let's have a look. Look, just very quick. Cancer, and they are positive. It's true positive. This is what we want. This is very good. This is positive. Then we have, don't look down, look diagonal. Diagonal, this is not cancer, and they are negative, which is also what we want. So true positive and true negative, we want to maximize this. We want the test to be as high as possible here. And if you look diagonally on the other side, false positives and false negatives, we want to minimize this in a test. So the test that has this diagonal side very high is good, while this diagonal side very low is also very good. Shouldn't be high. If this is high, it's not good. Now we go to the sensitivity. This is true positive, false negative. Some people like to use these equations and memorize them by heart. But before memorizing them by heart, you should understand them. It makes it easier for you to memorize. So look vertically here. Cancer, if you remember the definition of sensitivity, we said that sensitivity deals with positivity. So which one is positive? Is this one. Cancer. Cancer. So we have cancer. How many positive cases of cancer we have? They are cancer and they are positive. 90. Total, 100. So 90 over 100, this is their sensitivity, which is true positive, the real case, true positive, over total of them. True positive plus false negative. So this is 90. Another vertical looking is this. Healthy, no cancer, undiseased. We are, if you remember in the definition of specificity, we said that it deals with negativity. Which one is negative? This here, true negative. So we have this 810 over the total, 900. So it's true negative over false positive plus true negative. Okay, so it's going to be 90 and 90. Okay, so usually in a theoretical setting, you will have this 100 and 100, and this would be ideal. But you will never find this except in heaven. In real time, in real situation, on the ground here, you will have 90, 95%, 85, 88, and so on. And usually you don't have them both very high. Sometimes one on the expense of the other. You will find sensitivity very, very high and specificity very low. Not very low, but low. Because if you want to have sensitivity very high, it means that you are going to detect very small, minute amounts of concentration of the analyte. Then when you are going very deep down to get this minimum concentration, nanograms, then maybe you are going to capture analytes other than the one you want. It will be false positive. Okay, so you have to make a compromise here. I want to go down until I reach reasonable concentration of the analyte, but I shouldn't go beyond this because otherwise I will pick up other analytes which I'm not interested in. Understood? So there is a balance here. You have to make a compromise. So this is the idea of sensitivity and specificity. So you are talking about cancer and non-cancer, the positives in the cancer and the negatives in the non-cancer. Now, as Muhammad asked me, you have now the positive predictive value and the negative predictive value. We don't look at the cancer group as the first thing. We look at the positives and look at the negatives. How much positives, and they are cancer, over, yes, 90, over the total. And how much non-cancer, negative, and they are healthy. They are 820. So the idea in the sensitivity and the specificity, you look in the cancer and non-cancer, and you go down vertically, and in the positive predictive value and the negative predictive value, you look at the groups of positive and negative, and look if they are really healthy or unhealthy, diseased or undiseased. So this is the difference between them. Okay, I think it's clear. Yes, good. So now we go to the accuracy. Accuracy also, it has a analytical definition and a diagnostic definition. Let's keep it the diagnostic definition, which we want is the how much cancers and they are positive, or how much positive and they are cancer, which is the true positive. We should increase this. And at the same time, how much healthy, undiseased, or non-cancer, and they are negative. Also, we should increase this. These two here, which are diagonal, the higher, the better, because they are the accuracy. So it's 90 plus 810 over the total diagonal. Go diagonally, 1000. So this is positive. We should have this diagonal very high, and we should minimize this. The positive of this should be minimized. Okay, so this is the accuracy. Accuracy usually in the analytical definition, it means that you are detecting the true value. Negative, negative, you are detecting the negative. Positive, positive, you're detecting the positive. Okay, that's analytically speaking, but this is diagnostically speaking. Okay, so if you go to clinical chemistry lesson, you will find almost the same, but they will talk about the concentrations and this stuff. Okay, sometimes in the exam, we try to trick the student. How? This is cancer and this is non-cancer, diseased and non-diseased, and this is positive and negative. So you can just put positive here and negative here, and cancer here and non-cancer here. So we can see who of the students understood what we were talking about and who just memorized. Okay. Then criteria 4, acceptability. So patient should accept the test, whether the test is screening or confirmatory, because sometimes in colon cancer, you are going to use colonoscopy and it's very invasive to the patient. You have to insert, let's say, in the anus something, and then, or you can open in the stomach and just put it inside. Colonoscopy. So this is invasive and patients don't like it. They don't feel happy with it. Inconvenient. So acceptability is, and that's why the confirmatory test is not something you do daily or you do very often. Maybe none of the tests are done daily, but very often. Very often is we do screening tests, quick, yes, and non-invasive. And convenient, yes. Harms, invasiveness. So sometimes, let's say, you make a test and you have to open an incision in the stomach. So some people might get some infection after this. Secondary infection, bacterial infection. So harm can exist. Also catheterization. If you put the catheter, also it can be invasive and can bring some infection. Surgery, post-operative infections. Also this can happen. So harms can occur. That's why we should be very careful. It's something we do every several years, maybe, for those who are under risk, not for everybody. Not anybody does confirmatory test. I mean, you don't say to the doctor, I want to make colonoscopy just for fun. No, colonoscopy is when you need it or when it's really indicated by the doctor. Cost and frequency of test. As I said, breast cancer is once a year for women about 35. If this was history, then once every 6 months. And as you grow older and you have a family history, maybe it should be every 6 months. Also, the cost. Confirmatory test, biopsy, and these stuff, they are costly. You have to take biopsy, so somebody has to take the biopsy. Also, it's costly. Somebody has to make the histopathology. Also, it's costly. It's not like very quick tests. If the lab test, FBS, it's only one test, maybe a few dollars. But if you are going to do OGTT, within 3 or 4 hours, you are going to take from the patient 4 times. And plus, each test, each time here, it's going to cost you. Okay? So convenience, cost, time, all of these. Colon cancer, once every 2 years, maybe, because it's more invasive. So this is the idea. Acceptability, it should be accepted to the patients. And nowadays, the patient has to take decision with you, participate in the decision, and have to sign a consent that he or she allows you to do 1, 2, 3, this procedure. Some patients, they don't. So you have to say, okay, if you don't, just tell him the advice and tell him that you are going against advice. These are few just examples or how they meet the 4 criteria of screening. So example 1 is hypertension. You can see here the 4 criteria for screening. Mortality and morbidity. If you don't make diagnosis for your hypertension on time and you just ignore it, you are going to have stroke, myocardial infarction, and kidney diseases. Okay, and then death after this. Early detection. You can detect your hypertension years before it develops by just measuring blood pressure. Very simple. And treatment is available. So early detection and improving the outcome, these criteria. Feasibility. Nowadays, you can just buy this sphygmomanometer at home and you can test yourself for hypertension. 2-3 times you are abnormal, go and make double check in the hospital using the sphygmomanometer in the hospital. Maybe it's more professional. And then after this, you can be diagnosed. Normal range is established, no problem. We know the normal range of hypertension, blood pressure, 120/80 millimeter Hg. Above, then there is a problem. Accessibility, screening is harmless. I mean, measuring your blood pressure is something very easy. You don't have to make any preparations or something very invasive, no. Okay, low cost. You can do it sometimes for free, or you can buy just the sphygmomanometer. Okay, acceptable to the patient. The patient will not be harmed. He will enjoy blood pressure being measured. That's hypertension. Now, the 4 criteria, how they apply to breast cancer. Morbidity and mortality, second most fatal cancer among women. Maybe the lung cancer comes first after the woman started to smoke. Yeah, previously the women were not smoking, so breast cancer came first at that time. But now we managed to bring the woman to the square of smoking, so they get that's what they get. Early detection, there is a possibility of early detection. You can detect the woman in stage 0 or 1 and save her life. Early detection improves outcome. It's not like lung cancer. Yes, lung cancer, you detect, it's too late. Feasibility, mammography. You can do mammography, and mammography is feasible and accessible and affordable. Now it's in every hospital almost. Harm can be due to false positive. Imagine that you have been told that you have cancer, and in fact you don't. Imagine yourself going through the chemotherapy or maybe mastectomy or this, and everything was false. That's a problem. Acceptable to the patient, mammography, and screen less than, yes, it's costly a little bit, especially if you are going to make the confirmatory test. It's a little bit costly. Screening less than 40, 35, 40, and you have to keep screening. If you have a family history, you have to keep screening until the end of your life. And with family history, maybe every 6 months. Without family history, maybe it's 1 year. Okay, let's apply the 4 criteria to cervical cancer in women. Fatal if undetected and untreated. That's why all women who visit the gynecology clinic and they are married and they have babies, they had babies, one of the almost routine tests is the pap smear to detect if there is cervical cancer or not. Okay. Early detection improves outcome. So if you detect early, you can save the lady. Feasibility, pap smear, papinicular smear. Accessibility, high false positive. That's why you have to make the screen, and if it's positive, where do we go? Confirmatory test. This way you can reduce or delete or omit false positive. Screening and confirmatory, then false positive becomes minimal. Okay, and now we have other tests also. DNA testing, mutation. You can test even in old cancers. In all cancers, you can test number of mutations that are related to that cancer. You know, mutations, SNPs, single nucleotide polymorphism. Okay, colon cancer. Second most fatal in men and third in women. So colon cancer can affect both men and women. Early detection, usually they detect sometimes if there are polyps, you know, polyps in the colon. These polyps at the beginning, they are normal. Just they are appendages and they are normal. If you just leave polyps and don't act quickly, then these polyps, most probably they are going to develop into cancer. And then when they develop into cancer, they become capillary rich, lots of veins, like a cancer. And then every time there is a peristaltic movement of stool inside, then they touch or they scratch the polyps, and the polyps will bleed. At the beginning, the bleeding will not be seen by naked eye. So you have to go and test by occult blood, hidden blood. And you should not wait until you can see the blood, because by the time you see the blood, it becomes too late. Feasibility? Okay, we have a very simple test, very simple, non-invasive. It's fecal occult blood, hidden. It's in the stool. You take stool sample and you put small stool sample. It's like a booklet, small booklet. And then you put it in the booklet and close it. And there is a window on top of the booklet. You just add the reagent and it should turn into purple. If it's purple, then it's positive. Okay. After this, if it's positive, do it once and twice, 3 times maximum. Then you are confirming the presence of blood. Then you have to do colonoscopy, because not all blood comes from cancer. It can be something else. It can be hemorrhoids. Accessibility, colonoscopy is costly and invasive. Colonoscopy, it's available in all hospitals. Okay, but it's costly, and patients don't like it because it's invasive. But if you have occult blood 2-3 times positive, then you have to go there. I mean, you have no alternative. If you don't want, then you are committing suicide. Okay, we can stop here for today. Any questions before we go? No questions? Okay. See you next time.